So 2016 is the 40th anniversary of the Barkley Memorial Center. And yes, the Barkley Memorial Center is a building and has, 3 program areas within it. And certainly those training programs have a history that's much longer than 40 years. In fact, our training programs date back to the 1920s, some of them. But a special thing happened in the early 70s. Well, actually before that, with the Barkley family. So for those of you who've been in my office, you've noticed these 2 pictures on the wall of Mr. and Mrs. Barkley. And Mr. Barkley did a lot of things, but rose up in various jobs and was a bank, very high level in banks, and very savvy with money, I think, made some wise investments during his career. And his wife actually was a school teacher and also served a period of time as the Dean of Women at the University of Nebraska-Lincoln in the early 1900s. And Mrs. Barkley lost her hearing as she aged. And then as they went into their later years, they established a fund for the university to train professionals to teach children who were deaf or hard of hearing, to work with children with speech and language impairments, and to work with adults who were deaf. And that money in the early 1970s had developed to quite a generous amount of money. So the campus developed a committee who decided what to do with it, and they recommended that the campus build the Barkley Memorial Center to establish and support programs that they otherwise would not be able to have. And that's how this building was started, and it was dedicated in 1976. And when it was established, it housed the Division of Special Education, the Department of Speech Language Pathology and Audiology, and the Specialized Office for the Deaf and Hard of Hearing. And those 3 entities worked together since that time to what we have become today, which is the Department of Special Education and Communication Disorders. So in celebration of our 40th anniversary, we thought it would be a good idea to bring some outstanding alumni back to us and to tell us a bit about what they've been doing since they left us. And so Ryan is going to initiate our Outstanding Alumni Seminar Series. And I think Ryan's work certainly ties in with the mission of the Barkley Trust, and so I'm really thrilled to have him here today. But let me just tell you a little bit about Ryan. So Ryan got his bachelor's degree from the University of Northern Colorado, and then did his master's degree work here, and graduated in 2002, and then went away for a while, and then came back to finish his Ph.D. in 2011. And Ryan is currently the director of the Center for Audiology at Boys Town National Research Hospital, and he also directs the Audibility, Perception, and Cognition Lab at Boys Town, and works as a consultant for British Columbia Early Hearing Program. And those are all well aligned with Ryan's interest in pediatric amplification. Ryan has had a number of grants from the National Institutes of Health, either as a co-investigator or PI. He currently has an R01 that is on complex listening skills of school-aged children who are hard of hearing. So this is certainly a challenging area to study. I hope you're going to tell us a little bit about that work today.
I did include some stuff.
Okay, excellent. And so he's been quite well funded and very productive. He has 33 peer-reviewed publications, 3 book chapters, a whole slew of online publications in trade journals, practitioner outlets. He definitely is very generous with his knowledge, and I think some of you have probably even seen him respond to emails on the ASHA listserv. So he's very generous about sharing his expertise with people. He has also been invited to present really very widespread across the nation about pediatric audiology and issues related to hearing in children. And then lastly, I'll just point out that he received the honors of the association from the Nebraska Speech Language Hearing Association, and was an early career awardee from the American Speech Language Hearing Association a couple years ago, and we were honored to help have a reception to celebrate his work. But today he's joining us as our outstanding alumni for audiology. So welcome, Ryan, and we're thrilled to have you.
Thank you. Thank you so much. It's incredibly flattering to be here and to be invited to share some of the work that we're doing with all of you. When Sherry said that they were going to have outstanding alumni, I thought she was going to say, but until they get here, we're going to have Ryan give a talk about it. So it just doesn't even seem real to me to get this kind of honor, and it means a lot to me to get this kind of recognition from a place that I think I owe a lot to in terms of the work that we've done. And I'm going to talk a little bit about that today. But there's my email address if you want to email me and tell me how terrible the talk was later. So these are my conflicts of interest. In an election year, I think it's always important to point out who's paying for this, and these are the people who are paying for this, so I'll just put that up there. But I want to talk for a minute about the Barkley Center, because it's really the place where not only I got my clinical training, but then also did my Ph.D. and had a lot of research. So here's a picture from when I started in the master's program in 2000, and then I finished my master's in 2002 and have worked at Boys Town National Research Hospital since that time. And here I am when I started the Ph.D. program, very excited and happy to be starting the Ph.D. program. And then here's a picture taken at my graduation at the end of the Ph.D. program. So you can see things have improved. I'm feeling a bit better. I've recovered from the Ph.D. But it's a huge honor. The Barkley Center really made a lot of the things that I've done in my career possible by funding my education through my master's program as well as in the Ph.D. And I think it really set me up to do some pretty cool things that we're gonna talk about. So one of the other things that you'll notice about this timeline here is that there were some fortuitous things happening in the field of pediatric audiology at the same time that I was going through all of this training. And that is that around the United States, we were developing universal newborn hearing screening programs and early hearing detection and intervention programs and methodologies for fitting children with hearing aids at younger ages than we'd ever been able to do before. And so these were great achievements, but then it created all these new problems. So it reminds me of this quote from George Bernard Shaw, which is, "Science never solves a problem without creating 10 more." And that was a really good thing for me because this whole new population of children needed to be studied and needed to have methods to serve them clinically, and that has really been what I've been doing since I started in the field. So we're going to talk about three different sort of aspects of the research that I've been involved in, and one is we have newborn hearing screening, and that's great, but if you don't actually do anything after newborn hearing screening, then it's not a very effective process. You have to have a diagnostic process for fitting infants with hearing aids and estimating their thresholds before ages where they can participate in behavioral assessment. And before newborn hearing screening, kids were 2.5 or 3 years old before we were identifying them with hearing loss. By that time, we could test them behaviorally in most cases. But now we have this new population of babies that we need to fit before they're 6 months of age. And the only way to do that is through some of these new electrophysiological techniques. So we'll talk about some research that I've been involved in with that. Then there are all kinds of questions about how do we optimize amplification for children, and that's been sort of another phase of the work that I've done. And then some of the more recent stuff that's related to my current grant, which is what are the factors that predict success with amplification. So those are sort of the three areas that were doors that were open to me because of the timing, essentially, of my interest in pediatric audiology. So we're going to start talking about those diagnostic challenges. Here are two individuals who are researchers at Boys Town. Many of you probably know Michael Gorga and Doug Keefe. And I was a clinical audiologist at the time when I got involved in both of the research projects that I'm going to talk about. And it was interesting because if you know Doug and Michael, they probably not collected data themselves on patients, maybe in their whole careers. I know Doug hasn't. And it's been a long time since they let Michael see a patient. So when they have these really good ideas about research, they need people to help them to collect the data. And that's sort of how my first introduction to research was getting conned into working with these two guys, which ended up being a really good thing. So one of the first problems that we had with identifying infants through newborn hearing screening is that we needed a way to estimate what those infants' hearing thresholds were before we could establish what those were behaviorally. So if you're going to fit hearing aids, you have to know how much hearing loss a child has, and it has to be pretty accurate because we're going to base the amount of amplification that we're going to provide on how much hearing loss they have. And it also will tell us which kids probably aren't going to be successful with amplification and who are going to either need to go on a cochlear implantation or some alternative form of communication. So the way that we do this is we had these auditory brainstem response tests where we can measure the brain's response at the brainstem level to sound, but we didn't really know necessarily what the relationship directly was between the behavioral thresholds and these electrophysiological measures. So Michael published a paper in 2006 that tried to establish correction factors so that you could measure an auditory brainstem response threshold from a baby and then tell what the threshold was going to be, so you could use that information to fit hearing aids. And the correlations between the behavioral threshold and the auditory brainstem response threshold were very high, like in the neighborhood of 0.9, like where if you see these correlations in your data, you're wondering if you made a mistake, they were so good. But then we also noticed something in the data that was a little bit interesting, and that is that you've got this sort of slope. So this is the difference between the ABR threshold and the behavioral pure tone threshold as a function of the pure tone threshold. And what you notice is that for people with normal hearing who are down here at 20, that we're sort of overestimating the amount of hearing loss that they have. So the ABR threshold is higher than the behavioral threshold. And the reason for that is that we don't test down to the same levels that we test behaviorally when we do an ABR. So this is really not something that we're too concerned about because we're still going to call those people normal. What we are concerned about, though, is this group of people up here where we're underestimating the degree of hearing loss. And what that means is that the ABR threshold is going to be better than the behavioral threshold. And what that means is you're going to provide less amplification for those kids. And these are precisely the kids who probably need the most amplification. So it's a major problem. But Michael made a mistake in this paper, and that is he plotted this relationship as a function of the pure tone threshold. And the problem with that is that when you're testing a baby in your clinic, you don't know what their pure tone threshold is. So we needed to characterize what this relationship was as a function of the ABR threshold. And when he realized that, they had published the paper. But if you know Michael, he talked about this basically every single day from the time the paper was accepted until he could find someone to work on this project with him, which I finally said, I'll do it. So he would stop bothering me about it. So I was a clinician at the time. And these are an example of the data that we collected from the clinic, basically. And you can see in our uncorrected data here for a 500 hertz tone burst that we're still seeing the same relationship that Michael saw in that paper. And if you apply common correction factors to those data, you can see that we're getting better for the people with normal hearing. We're getting closer to an accurate prediction, but we're actually kind of making things worse for the people with the greater degrees of hearing loss, so that's great. You have a stronger assurance that people are normal, but then your estimate for the people who really need amplification is worse. So what we did instead was develop just a linear regression correction factor. So we took the relationship between the difference between the ABR and the behavioral threshold and the ABR threshold and varied the correction factor as a function of the degree of hearing loss. So we're still making reasonably good predictions for people with normal hearing, but we're also making better predictions for people with greater degrees of hearing loss, allowing us to more accurately fit amplification. So this was a really cool project because it gave us the opportunity to marry some really good science with some clinical work that we were doing and adopting this in the clinic. So it was a very exciting thing that was a great opportunity to be a part of. And you can see here the effect that this has, comparing the constant correction factor, which is clinically used in the hourglasses, with the uncorrected, and then our linear regression correction factor. And for every frequency and degree of hearing loss that we evaluated, the linear regression correction factor was a better predictor. So this is currently something that we're using in our audiology clinic. So the other problem that we had in the clinic was that I was the supervisor for the Universal Newborn Hearing Screening Program at Bergen Mercy Hospital in Omaha. And the problem that we had is that only about 1 to 2 per 1,000 live births actually has hearing loss in Nebraska. But our day one refer rate at Bergen was about 20 to 30%. So this means on the first day that you test an infant, and they're all gooey from just being born, they're not passing their newborn hearing screening, and that means that either the family discharges and they have to have a diagnostic test later on that they don't need, or you have to test them again on the second day, which is expensive. And so Doug Keefe had this technology that he had developed that allows you to characterize the wideband response of the middle ear system in infants automatically using a click stimulus and by varying the pressure. And so we thought, well, this might be a way to tell which of these babies is not passing the first day because they have gunk in their ear, using that really scientific technical term, and which ones are likely to have hearing loss, because if you have a limited amount of time, you want to focus on the babies that look like they have a normal middle ear but still aren't passing their newborn hearing screening. So we use this wideband absorbance measure, and I have to be honest that the only reason that I included this in my talk was because I rarely get to show 3D waterfall graphs like this. But you can think of this just like a tympanogram, for those of you who are audiology students, in that we varied the pressure, but then we also varied the frequency. And what you can see here for babies, this is the 50th percentile for babies that pass their newborn hearing screening on the first day. And this is the amount of energy that's being absorbed by the middle ear. So if we play a sound in the ear and then measure how much of that sound gets reflected back at different frequencies as we sweep the pressure, that's what it looks like. So you can see a lot of energy is being absorbed by the middle ear at very specific frequencies. But you can see for babies that didn't pass their newborn hearing screening, less energy is being transmitted. And sure enough, these infants, when we tested them on day 2 in this study, would pass their newborn hearing screening. But this is a way that allows us to sort of prioritize or to figure out very early on who are the kids that we suspect actually have hearing loss and who are just the gunky kids that need more time for their middle ear to sort of pneumatize and get air in it. So I played a minor role in these studies, but it really showed a great example of how having clinical background and having clinical experience and connections can help with these research projects and to make those connections. So it was a really great experience for me to be a part of that, and that really sort of lit a fire, I guess you could say, for clinical research for me. So sort of the second phase is a bit overlapping with the first. And that is, the first project I'm going to talk about was my awful master's thesis. And it really was awful. But how that led to some of the other work that we've done with speech recognition. So Dr. Boney and Dr. Carroll supported me on that master's project, and then later, when I started working in Pat Stomakowitz's lab, all 3 of them were on my doctoral committee for some of the other work that we did that I don't think was as awful as my master's thesis. So my master's thesis was doing sentence recognition with adults with normal hearing using amplitude compression, which is a way that for people with hearing loss that we compensate for the loss of the dynamic range with amplification. So it turns out that when you get hearing loss, your ability to hear loud sounds doesn't increase, so the dynamic range that you have to listen to speech is much smaller. So if we just try to make everything louder, you're going to complain that it's too loud if you have hearing loss. And so we have this way of sort of squishing the signal into your dynamic range. I don't know why I thought adults with normal hearing needed to listen to amplitude compression, but there were a lot of adults with normal hearing around, like my fellow master's students at the time. And I think Dr. Pritchett was a subject in this study. I probably still owe you a drink for that. Yeah, well, my lawyer said we can't talk about those things today. So we did conditions that were linear and sort of like a hearing aid 3-to-1 compression and then a 9-to-1 compression ratio. And the only scientific conclusions that I could draw from this data were that adults with normal hearing have really good speech recognition because you can destroy the temporal and spectral characteristics of the signal with a lot of compression, more than you would ever use in a hearing aid, with a group of people who would not wear a hearing aid. And they can still recognize speech really well. So you won't find this published anywhere, and there's good reasons for that. But all joking aside, it was a really valuable experience because it set me up for some of the other work that I was going to do later in my dissertation. So one of the big problems that we have when we're fitting hearing aids is that we need a way to quantify how much of the speech signal is being made audible through amplification for a given degree of hearing loss, because it gives us a way of knowing how much speech is this person going to realistically understand. And so we've developed this thing called the Speech Intelligibility Index. And essentially, it's a number between 0 and 1 that just characterizes the weighted proportion of speech that's audible to the listener in a given situation. And you can use these transfer functions that have been developed to predict speech recognition as a function of how much of the signal is audible. So you can see here when very little of the signal is audible, speech recognition is very low, but then you see a growth essentially depending on whether we're talking about something that has a lot of linguistic context, like continuous discourse. Adults only need about 40% of the speech spectrum to be audible in order to understand continuous discourse, because they can use their knowledge of language and linguistic context to help them to sort of fill in the blanks. Whereas if you're having them listen to something with very little linguistic context, like nonsense syllables, they need a lot more of the signal to be audible in order for them to hear it. And we were applying these data that we had to children who were wearing hearing aids. So we were trying to make predictions about how children would recognize speech based on these data that were collected with adults. And as a clinician, I thought that was really weird. But if you've ever participated in one of these studies, you can understand why no one did it with kids, because you're essentially taking the signal and taking chunks of it away and having these kids listen in background noise. So these kids, 5 to 12-year-olds in my dissertation, were listening to speech at very low signal-to-noise ratios where we've taken away the speech information, and their speech recognition was very poor. And the kids just absolutely hate it. So people said, you're never going to get kids to be able to do that. So we made some design modifications and collected the data as part of my dissertation. And the other thing that we did was we decided that we were going to limit the linguistic context as much as we possibly could, because we wanted to take away any advantages that adult listeners might have in terms of the speech recognition task. So we took these very short nonsense words, so they're not real words, so having a better vocabulary isn't going to help you to recognize them. We even balanced for the phonotactic probability of the segments in the non-words. And what was interesting is that we still saw an age effect there. But we also were able to get these transfer functions that show that even when young children, 5 to 8-year-olds, have full audibility of these nonsense syllables, they're still going to miss some. And so maybe this is a better guide to use instead of those transfer functions that were developed for adults. So, but this also got us thinking about something I'm going to talk about later, which is why, if we control for all of these linguistic things, why are we still seeing age effects? And I think we have an idea. So then Pat Stomakowicz noticed that I was doing all this work with audibility with kids, and she's like, well, we have these new types of signal processing in hearing aids called frequency lowering. And I'm thinking that some of the work that you're doing related to this speech recognition stuff in noise might help us on these projects of figuring out how to measure audibility with frequency lowering. So frequency lowering is designed for people that have very little hearing in the high frequencies to take that information from the higher frequencies and move it down to lower frequencies where you have better audibility. Now the problem with that, as you would imagine, is that you're distorting the speech signal when you do that. And you're taking things that normally sound like an S or an SH, and you're making them sound a little bit more slushy because you're lowering the frequency. But the point is that people who have hearing loss are having distorted perception of the auditory system anyway. So maybe if we just make that cue audible, we should be able to do that. But when this first came out, we didn't have a way of sort of figuring out how much compression to use. So one option would be to just turn it all on and give them as much compression as possible, but then you're going to be distorting the input. So we needed a way to measure the audibility so that we could balance the distortion and the audibility that we were measuring, and this is what we tried to do in this project. So again, with our history of testing normal hearing listeners in conditions that they would never actually be in, but here we had a good reason for doing it, and that is, if you don't see the effect that I'm going to show you in a minute in normal hearing adults, you won't see it in adults with hearing loss either. So the idea here is we took these different conditions and we varied the audibility by adapting the amount of compression. And so if our prediction held true, then you should see a very orderly increase in speech recognition as a function of audibility. But if you're seeing distortion, then the results will kind of be all over the place because they won't line up in terms of increasing audibility. So this is what we found. And that is, here's their unprocessed, and then each of these conditions represents a different simulated audiogram for these adults with hearing loss, or a different amount of filtering that we applied to the signal. But if our prediction was correct, what you should see is an orderly increase in speech recognition from the condition with the least amount of audibility to the condition with the most amount of audibility, and that's exactly what we saw, as you can see here. So we met our predictions in listeners with normal hearing, and the associate editor in Ear and Hearing, despite the fact that this was with normal hearing adults, thought this was an interesting concept, so we were able to get that published. But those of you who work with adults who have hearing loss know that we can't make assumptions about whether this would work with adults based on our normal hearing data. We knew that if it didn't work in the normal hearing listeners, it wouldn't work with them, but then we needed to go and collect more data with listeners with hearing loss. So we got a group of adults and a group of children, and here are sort of the ranges of audiograms. So these are listeners with mild and moderate hearing losses, a lot like you might see in the Barkley Center Clinic. And our hypotheses were that children were going to get more benefit from this than adults because children rely more on the acoustic phonetic information that's in the signal. And so they put more weighting on that. So the idea is if you're making that high frequency information more audible for them, that they're going to get bigger benefit from that. We thought that if we gave them exposure to the signal processing, so we took these children's stories about a frog because it had a lot of fricatives in it, and we processed it with the signal processing and had them listen to it. And it was about a 12-minute exposure to the signal processing, thinking that that might help them to get better at this. And then we thought that we would see an effect that would be based on our audibility model. So again, on an individual basis, we expected that listeners who were getting more audibility with the processor would have better results. So not all of our predictions held. So this is before the story and after the story for children and adults. And statistically, the children and the adults are not different in terms of their benefits. So the open box plots here represent the conventional processing. The hatched box plots represent the nonlinear frequency compression condition, and you can see that there was an increase in speech recognition for both groups, and it occurred without any exposure. So we did see an increase in both the conventional processing and frequency compression between pre and post, but it wasn't signal processing dependent. So this relationship, this increase, was maintained before and after, and that makes us think that it was a practice effect, but really what we needed to have was a control group that didn't get the exposure to answer that question. But at this point, the adults and the children received pretty similar amounts of benefit from the processing, which we thought was pretty surprising given that we know that children benefit more from that high-frequency information. Our audibility calculation indicated that listeners that had an increase in audibility were more likely to have an increase in their word recognition. So anything basically from -5 to 5 on our task is not a significant change in speech recognition. But you can see the people who are in the green box are the people who met our expectations in terms of improvement. So the black circles are the kids, the open circles are the adults, and you can see that when we increase audibility, we get a proportional increase in speech recognition, but not always, right? And we're exploring this right now, and this is why we always look at the individual data, because it would have been really easy based on the group effects to just say, you know what, we're not really interested in these two people down here, but we work in a clinic and we still have to make these two people happy or they're going to return their hearing aids. So I'll talk about a little bit later what the next steps were in trying to figure out why those two people who had an increase in audibility actually got worse. So the point that I want to make here is that my master's thesis was terrible, and I appreciate the fact that Dr. Boney and Dr. Carroll never told me that. Because they could have. They both, have done really interesting things, and so, I'm sure this master's student who was taking up their time was like about the last thing they wanted to worry about. But this method, this practice, and the ability to do this research through the Barkley Center gave me the opportunity to get experience testing speech recognition and designing a study and doing all these things. So it was really beneficial when I got into my research life where I needed to be able to do these things and have that experience to know we're not going to do that again. So the last section that I'm going to talk about is just the sort of final phase of what has been my research life so far, and that is being in the right place at the right time. So right after I finished my Ph.D., I was sort of at loose ends. I wasn't really sure that I wanted to hang around at Boys Town and write grants to keep my job forever. And so I was looking at options in industry, I was looking at academics, and I was thinking about whether or not I wanted to stay at Boys Town, and I got this phone call from Mary Pat Moeller. And when you get phone calls from Mary Pat Moeller, at least when I get phone calls from Mary Pat Moeller, I always answer the phone. And she said, you know, Pat Stelmachowicz is retiring very soon, and we really need someone who's involved in audiology to join our project. And I was like, well, that would be really cool, because I'm really excited about the work that you're doing. And so I got an opportunity to move on to this longitudinal research project known as the Outcomes of Children with Hearing Loss Study. And this has been an incredible opportunity, so I'm going to share some of the data with you from that project. And I don't know why Melody Harrison pops up first on this slide, but I haven't ever changed it just because I think I like Melody and I want to highlight that she's part of the project. But this is the whole team. So on one hand, you can look at this slide and you can say, boy, it's really cool to work with all these different disciplines on a longitudinal multi-center research study, but those of you who've ever done a longitudinal multi-center research study will look at this slide and say, how did you get any of these people to agree on anything? But somehow we did. So we did this study with the University of Iowa, University of North Carolina at Chapel Hill, and Boys Town. And the goal was to get an epidemiological sample of children who were hard of hearing from around the United States, between 6 months of age and 7 years of age, where English was the primary language, and there were no other disabilities going on there. So this represents sort of that 60% of children who with hearing loss who don't have additional disabilities. And then we recruited a cohort of age-matched and socioeconomic status-matched kids with normal hearing. So this is where the sample came from. You can see the primary recruitment sites there, but we actually traveled down into Kansas and Missouri, Minnesota, Illinois, a lot of the surrounding states to try to recruit kids. And what we ended up with was a sample of about 317 children who wore hearing aids and 117 age and SES-matched peers with normal hearing. So again, thinking about the previous research in developmental outcomes in children with hearing loss. This is Mary Pat's paper from 2000 that was in Pediatrics, which is a wonderful paper. And it shows that the age of enrollment in early intervention, the earlier you're enrolled, the better your language outcomes are going to be, which isn't, too surprising. But you got to remember that the average age of identification when she did this study was 2.5 years of age. So early enrollment in intervention is not at all what we think of it today. And in fact, the distribution of age of identification back then sort of looked like this here, where you had this initial group of children around a year of age who were identified with hearing loss because they were deaf and because they had profound hearing loss. But then there was this other group of kids who were sort of out at an older age who had lesser degrees of hearing loss, who maybe had milder speech and language problems, maybe they looked like they had behavior problems, but the point was, this is a very different group of kids than what we're dealing with now. And in fact, here's the age of distribution from our sample from the Outcomes of Children with Hearing Loss study. So the vast majority of the kids were identified through newborn hearing screening and fit with hearing aids before 6 months of age, and then you've got this very long tail of kids who are late identified, who are very different than late identified children previously. So some of these children who are late identified now passed their newborn hearing screening. So it's very likely that they didn't have hearing loss at birth and had some period of auditory experience prior to the onset of hearing loss. Some of them were lost to follow-up. So the early intervention programs, we didn't follow them or they moved or something happened. And some of them had mild hearing loss, so we didn't catch them later on. But if you think about that, that's a really different group of kids and a much smaller group of kids than we used to see as conventional late identification. So what you started to see in the research were these studies, especially out of Australia, where there was no effect of age of identification on outcomes for children with hearing loss. And this was sort of a red flag because it's like, well, that's been a tried and true effect that we've seen in the literature, and it makes sense, and we were really happy about that. And I think there's a good reason that we'll talk about in a minute, but basically it led a lot of these researchers to conclude that perhaps this wasn't important. And I think that's a huge mistake, as I'll talk about in a minute. But if you look at the factors that, for example, in Teresa Ching's loci study that were significant, predictors of outcomes, age at hearing aid fitting was not significant, but whether you were a girl or a boy, so girls did better than boys. If you had an additional disability, the more hearing loss you had, the poorer you did. Earlier you get a cochlear implant, the better. Higher socioeconomic status means better outcomes, and then children with oral communication did better than children who weren't using oral communication, but the outcomes were all oral communication measures. So that's maybe the least surprising finding of their study. But in this paper, Teresa Ching says that she doesn't think that hearing aids help children with mild hearing loss because of the fact that there was no effect of the age at first fitting. And any of you who've taken a statistics class can look at this distribution and understand probably why that is. There aren't that many kids anymore who are late identified. So if everybody's early identified, we wouldn't expect there to be some difference. And we think that the late identified kids now are very different on the whole than they used to be. So it's not that it doesn't matter anymore, despite the fact that that's what they concluded. It's that we don't have those kids anymore like we used to, where you can see that really stark contrast between kids that got early intervention and kids that didn't. And we should be happy that we have this problem, but it means that we have to look at other factors. The other thing that you'll notice about all of these positive predictors in the Ching study is that there's not a thing we can do about any of them from an intervention standpoint. So you can't give someone a disability or not. That's not within our control, unfortunately. I wish it were. You can make someone's hearing loss worse, but there's no way right now to make it better. So these are all things that are important, and they're demographic variables, but we really wanted to look at things that we could actually do something about. So we looked at outcomes and thought, well, maybe how much speech is audible interacts with how much these kids are wearing their hearing aids and their linguistic environment, and that's what documents outcomes. And the beauty of all three of these things is that they're malleable. We can do something about them. So this was our theory going into it, but there are some challenges with this idea that we'll talk about. So the first question that we had to ask was, how well are the hearing aids fit? Because if everybody's fit really well, we're going to have the same problem that we had with age of identification, where if everyone has really good audibility, we shouldn't expect audibility to explain differences in outcomes. So we looked at that in terms of how much of the speech intelligibility index we measured through their hearing aids versus what it would be ideally for their degree of hearing loss. And then how close were they to prescriptive targets? So when we fit hearing aids on infants and young children, we have a prescription that tells us how much amplification to provide. And obviously, the closer you are to that, the more audibility you're going to provide. So we were looking for kids with really good fittings and low errors as sort of the gold standard. Now, the problem if we saw that was that we wouldn't be able to use audibility as a predictor. But as you can imagine, that's not what we found. So these black bars and gray bars represent the actual fittings versus the ideal fittings. And if everyone was fit really well, you wouldn't be able to see the gray bars at all. So the fact that you can see the gray bars tells you that a large portion of these children are receiving less amplification than we would prescribe for their degree of hearing loss. So on one hand, we're excited that we're going to be able to look at variability in audibility as a predictor of outcomes. On the other hand, we wanted these kids all to be fit really well. So it creates a new clinical problem. So these are the clinical fitting data. This is the normative range for the speech intelligibility index as a function of degree of hearing loss. The circles are the right ear and the triangles are the left ear. The kids in the open symbols are kids whose fittings deviated more than 5 dB from the prescription. So you can see that the children who fall outside the normative range on the whole typically have fittings that are very poor, and that's what's dictating the poor fitting here. So it's not that these kids should be having cochlear implants and that's why we can't give them audibility. It's because of the fact that they're not fit well. So the other thing is we wanted to look at the effect of hearing aid use, But if everyone's wearing their hearing aids all the time, then that's not going to predict anything either. And again, unfortunately, that's what we saw. So this is interesting because as audiologists, what do we tell our parents of young infants and children that they should be doing when we give them hearing aids? Like, how much should they be wearing them? All waking hours, right? Well, babies sleep a lot, but the average here is about 4 hours a day. And as someone who recently had an infant, I can understand why this is. But it sort of raises questions in terms of what should we be telling parents and what should we be trying to do to encourage more hearing aid use, because 4 hours a day to me doesn't seem like very much, even for, because the infant group here went up to 2 years of age, so that's a pretty limited amount of hearing loss, or hearing aid use rather. So this was disappointing as well, but it gave us an opportunity to look at these factors as predictors. So as I mentioned, both of these things are attractive to us because if we can do a better job fitting the hearing aid, we can provide better audibility, and we can provide intervention to families to help them to understand how important hearing aid use can be. And there are people who are working on this as we speak. So this was a good news, bad news thing. We were excited that we had the variability to look at the effect on language outcomes, for example, but we were sad that there were so many kids who were fit poorly. And it actually created an ethical dilemma for us because as a researcher, you don't want to intervene in the study that you're conducting because that wasn't the point. I mean, we could have fixed all of the kids' hearing aids and given them better audibility, but that would have been a very different study. So instead, we followed these kids to see what the effects would be. And especially, I think, when you have other researchers who are out there saying that hearing aids aren't important, it becomes incumbent to show that this matters. So these are the data for language scores and audibility from a paper that Bruce Tomlin just published in Ear and Hearing. So this is chronological age on the x-axis. Normal hearing children would have on average would have a standard score of 100 at all of those ages. So the growth trajectories that you're seeing for the children who are hard of hearing that are positive are children who are sort of catching up or closing the gap with their peers with normal hearing. The different symbols here represent different quartiles of audibility. So the kids in the circles are children who have audibility that's below the median, and children in the triangles have audibility that's above the median. And this is controlling for degree of hearing loss so that we're not just looking at the children who have the worst hearing loss, but how much benefit are you getting from amplification. And what you see here essentially are that early on, we don't see big differences in terms of audibility, but once this has had time to play out, the difference that we see is almost 2/3 of a full standard deviation between the kids who had the best audibility through their hearing aids and the kids who had the poorest audibility. So this was incredible for us to see this and really reinforce what we were thinking about audibility. Hearing aid use was a little bit different, but it's the same concept. You have chronological age and language scores as your axes. Again, broken down by quartiles. And you can see here a difference in the trajectories between the kids in the filled circles who wore their hearing aids less than 10 hours a day at age 6, and the kids who wore their hearing aids more than 10 hours a day. So you can see there's 3 groups there, but that's sort of the delineation here, that hearing aid use matters as well. So this is important because, again, audibility and hearing aid use are things that we can actually do something about and provide intervention for. So audibility and hearing aid use were found to affect outcomes, and we can optimize those things by fitting the hearing aids really well and providing support for families and clear expectations about what families should do. So that means not just saying wear the hearing aids all waking hours, even if that's our goal, because it doesn't look like, at least for infants, that that's very realistic. And maybe our focus needs to be more on the types of situations where children should wear hearing aids and not just some amount of time, for example. So as we talked about in the beginning, this process of doing science can create new problems, and these are some of the things that we're working on right now. So one is individual variability in speech recognition, and the other is the impact of hearing loss on cognitive development in children. So remember those 2 outliers that I showed you in our speech recognition data with frequency lowering who were at the bottom of the graph, and we gave them audibility, and we couldn't figure out why they didn't improve in speech recognition. And those of you who fit hearing aids on adults know that you can give people audibility, and sometimes it doesn't help them. And we were interested in trying to figure out, well, what's going on in their auditory system that's preventing that. So we have this measure that's spectral temporally modulated ripple task, or the SMART task. And essentially the listener has to listen for spectral temporal modulations in noise that get progressively closer together. So I'm going to play you an example that's very easy, and hopefully you can hear it. So there were 3 intervals. Which interval was different? The third one, right? If not, you need to go see Dr. Wacker in the clinic immediately. I'm teasing. It's hard to hear that in here. But the idea is that you're listening for the one that's different. And the idea is that listeners that can better hear that change in frequency over time probably have better suprathreshold abilities and the ability to understand speech. And they've used this in the cochlear implant literature, and that's one of the reasons that we did this. And this is my postdoc, Ben, if you're wondering who this handsome fellow is right here that I put on the slide. So the take-home message here was that audibility was still important. So this is the speech recognition score as a function of the speech intelligibility index. And you can see that the more audibility you have, the better your speech recognition is. But even after we control for audibility, the relationship between spectral ripple discrimination and speech recognition was also significant. So we think that once you make it audible, that's important, because if you don't have it, if it's not audible, you can't do anything with it. But once it's audible, your ability to listen for those changes over time, which we know is important for speech recognition, is going to help to explain who might benefit from signal processing and who might not. The other problem that we're running into now is we have these children in our longitudinal study that we've been following now for over 5 years, and they're doing really well. So this is these are children listening to the AZ bio sentences, which are just child-appropriate sentences in quiet. And you can see the normal hearing children are down here, and the hard of hearing children all the way up to severe hearing loss are right here. And this is with their hearing aids. And what you notice is that everyone's doing really well. So this is good. This means that we're providing them with audibility through their hearing aids, and we are seeing a few kids that are having significant problems with sentences, but this is a really good thing. But then watch what happens when we put them in noise. So first of all, I just want to highlight the variability of the children with normal hearing in the same background noise as the children who are hard of hearing. And you see here that there's a lot going on here that's not explained by audibility. So this is a positive signal-to-noise ratio. The hard of hearing kids are wearing their hearing aids. And you can see for any given level of hearing loss, there's just extreme amounts of variability, despite the fact that these kids presumably have very similar access to the auditory signal. So this has led us to look at not only that spectral ripple measure in children, but also looking at working memory as a predictor of speech recognition. And sure enough, the children on this task who have better speech recognition also have better working memory ability, so they're better able to sort of hold on to the signal and use that for decoding. But when we started looking at these analyses, we found a third variable that was related to working memory and speech recognition that was a little surprising to us. And that is, we found a relationship between audibility and working memory. So this is something we're exploring right now, because there are data from David Pizzoni for children who wear cochlear implants that show that they have significant deficits in verbal working memory, for example. But these children have had pretty good audibility and have had pretty good access, but what you notice is that their verbal and visual spatial working memory abilities are both affected by how much the signal is audible. And if you're familiar with verbal working memory tasks where you're listening to something and repeating words back, for example, this relationship probably isn't surprising, because the kids who are doing poorer on the tasks have less access to the stimulus. But what's surprising to us is even when we do a visual spatial working memory task with these children who have hearing aids, even though those scores are higher and better, it still follows that same relationship with audibility, which suggests that there's some domain general process that's not specific to the auditory system that is affecting working memory development in these children who are hard of hearing. So this is something that we're monitoring over time. And it fits with Pizzoni's data, which those kids a lot of them would be down here in terms of their audibility. So the deficits that he's describing in those children with cochlear implants are gonna match with this. But we need to collect some more data to see if there's another variable like language or something that might also explain this relationship. So moving forward, The current RO1 that I have is called Complex Listening in School-Age Children Who Are Hard of Hearing, because we needed to come up with the longest possible title that we could for the grant. And we're looking at first and third graders who were followed as part of the Outcomes of Children with Hearing Loss study. And we're measuring them at first and third grade, looking at classroom acoustic measurements in their classrooms using iPods to see how their classroom environment might affect their achievement. Looking at their speech recognition and noise and reverberation as a function of some of those cognitive and linguistic variables that we were talking about. And then comparing subjective ratings, so like classroom questionnaires that teachers, parents, and even the children will fill out to see if the expectations of parents, teachers, and the children line up with their performance, for example, in background noise. So we ask a lot of questions about speech recognition and background noise on these questionnaires, but we don't know if these questionnaires are actually measuring that. So we're actually measuring their speech recognition and noise to see if those things line up, or if maybe parents have different perceptions than teachers, which I think is a safe bet. So Bruce and Mary Pat have renewed their RO1 in the Outcomes of School-Age Children Who Are Hard of Hearing, and they're looking at these kids in second and fourth grade, and they're focusing primarily on literacy and academic outcomes like math and spelling, advanced social cognition, so things like theory of mind that Mary Pat has been very interested in, and then also working memory and executive function in their grant. So we're collaborating and trying to come up with new questions and new areas to look at, and it's always an exciting time to get together with the whole research team to discuss these things. So I just want to take a minute and acknowledge the Barkley Center and the opportunities that I had here at the Barkley Memorial Center. The amount of support that I received really allowed me to be a part of all this research that I was talking about. I also want to acknowledge my collaborators on my current project. So Beth Walker at the University of Iowa, Mary Spratford, my research audiologist, Jake Olison, my statistician, Mary Pat Moeller, who I hope you all know, my postdoc Ben Kirby, Katie's husband Mark Brennan, who's a collaborator in my lab, and then Lori Leibold, who just joined us from the University of North Carolina. So, and of course, I'd want to acknowledge NIH and NIDCD for all the support that funded this work. So thank you so much for your attention. Right after lunch is always a little hard, but everyone's awake that I can see, so that's good. And I'll answer any questions that you have, but thank you so much.
Questions?
Have you looked at any aspects of listening effort in these kids and hearing aid use?
So I haven't personally, but I know that Beth Walker at Iowa right now is very interested, not only because we know from some of Anne-Marie Tharp's work that children who have less access to the signal are going to have to exert more effort. I think the question that Beth has that's very interesting is how much do linguistic and cognitive abilities sort of mediate that relationship? So you might predict that children who have poorer access have sort of two-pronged problems, and that is, one is that they lack access to the signal, but the other is that they haven't developed the linguistic and cognitive skills that they need to support them in those types of difficult listening situations. So it's almost like a double whammy. But again, those are things that we can intervene upon, and I know Beth is really interested in looking at that specific question about listening effort, because I think there are things that we're not measuring when we're just measuring their speech recognition and quiet, obviously. These kids have varying amounts of auditory abilities, but we're not getting at this when we measure their speech recognition and quiet, which is a good thing to think about if you're measuring people's speech recognition and quiet in the clinic. This doesn't look like a very good measure to me, except for maybe these few people.
How are they measuring listening effort?
So one way to do it is dual task paradigm. So the traditional behavioral task where you've got your primary task and then you're trying to do something else, like a lot of Dr. Carroll's stuff with like the sensory motor rotor type tasks. Another way that we've started to look at listening effort is using pupillometry. So measuring pupil dilation, in response to that, but that's a very difficult paradigm to do in children. So that's something that we're exploring as sort of a way to objectively measure it, but I think it's a long way from being ready to do that. So the other thing is there are questionnaires and rating scales that are available as well. So I think we're trying to take a multifaceted approach because I'm not sure that we even know what listening effort really is. Everyone's talking about it in audiology, but it's certainly, I know the group at Vanderbilt has done a lot of really good work looking at how to characterize that, but it's challenging because one of the things that we found in a recent study where we asked children with hearing loss to rate their confidence about how they did on a task is it's that sort of classic Dunning-Kruger effect where kids who did really poorly thought they did great, kids who did really well thought they did poorly. I mean, it was very difficult to get them to understand the difficulties that they were having. So I think we have a lot of work to do there, but that's a great question.
I have a question. So the two people who performed poorly, even though you gave them Audibility, that you then extended with that SMART test to try to understand perhaps why they did so poorly.
Yes.
So my question is really about what potentially could be happening in particular individuals. I mean, clearly their brain is processing the signal differently. I mean, it seems like to me, right? So what, I mean, do you have some thoughts on that?
Yeah, so one of the big issues that you're probably all aware of is that whole issue of synaptopathy that Kujawa and Lieberman talk about with hidden hearing loss. But these aren't hidden hearing losses because we know these people have them. But we also know that people with sensory neural hearing loss, that they have varying amounts of sort of nerve survival and you know, that sort of thing. So, and we don't really characterize that with the behavioral audiogram, right? Because you don't need too many inner hair cells surviving to detect that there's something, that there's a tone present or absent. And so part of it, I think, the variability that we see is just related to that variability in the nerve survival and things like that. But then I also think there, like you were talking about, that there are cognitive effects, you know, in terms of, you know, even if it's audible, it may be very distorted, and individuals who have better cognitive abilities, for example, in older age may be able to better tolerate that distortion or you know, or sort of hold on to that signal. So I think that's something that there's a lot of, I know Brian Moore's group is looking at some of those issues.
I mean, do you feel like there will be some malleable factor that you as a clinician would be able to address that would help these people further, or is this potentially as good as it might get for these individuals? And granted, you probably don't have an answer to that.
I have an idea. So if you came in and we made the signal audible acoustically to you and you still didn't have any benefit, that might be a situation where I'd send you over to the cochlear implant team, even though audiometrically you might not be a candidate, because there's nothing a hearing aid making it louder is going to do to overcome that. But we could change the implant criteria a little bit, and instead of making it based on the audiogram, we could say for people who don't benefit from restoration of audibility, we should look at cochlear implants sort of regardless of what their audiogram looks like. And I know that's kind of a far out there idea, but I don't know that there's anything, I mean, you can do a lot to promote the sort of slowing of the decline of cognition by providing early amplification, I think. I know Franklin hasn't published that data yet, but I think that's what it will show. And so I think providing hearing aids earlier will help with some of it, but if someone has damage to the inner ear from noise exposure, from too much iron butterfly or something, you know, we can't go back in the time machine and, you know, and give them earplugs. So in a lot, you know, or like veterans, for example. So I think we need to be thinking about how are we going to measure that clinically, and then, you know, what do we do about it? Because, you know, I think there are a number of people who aren't served by hearing aids because they have other higher level problems that we're not measuring with the audiogram.
Right, and we might see more people than we even know, right? Because we just say, my hearing aid's not doing anything for me, I give it back.
Yeah, and we all have those patients. I mean, not at Boys Town, no, I'm kidding, but no, I mean, everyone has that patient that you think you've done everything correctly, but when you think about what you're doing, you're restoring audibility based on the audiogram if you're doing a really good job, and there are a lot of people that don't even do that. So that's something to think about. Dr. Carroll.
So can you tell me a little bit more about the working memory part of the study? Like, were you looking at primacy and recency effects, or were you closer down to sensory memory, or what was the time frame?
So the working memory measures that we were using are part of the automated working memory assessment. So that includes both verbal and visual spatial working memory tasks that vary in terms of whether you have to do just storage of the thing. So like an example of that is like a non-word repetition task where you just have to basically repeat back an increasingly difficult non-word or string of non-words that you have to hold in verbal working memory. There's other tasks where you have to not only do that, but more like a reading span task where you actually not only have to remember, for example, whether a sentence was true or false, in addition to remembering the final word of each sentence for an increasingly lengthy sequence of sentences. So it's trying to separate out storage and then storage plus processing together for both verbal and visual spatial tasks. So it's
pretty fairly long-term and fairly cognitive.
Yes. Yep. We are interested, though. We're doing some experiments with multi-talker maskers right now, and we are really interested in sort of that memory for pitch. Because if you're thinking about multi-talker maskers, your ability to sort of separate out the target talker from the masker talkers might be related to your ability to sort of lock in on which one's the talker, and that could be, I think, related to more short-term sensory processes like memory for pitch or tones. So we're going to look at that.
Which harmonics go together based on
fundamentals. Exactly. It's a great question. Other thoughts, questions?
Yeah. In your current study that you're doing right now, are you going to look at FM system use? Or
Yes.
hearing aids?
So FM system use is really interesting because hearing aid use is really easy to talk about because hearing aid use, more is better. We want the kids to be wearing them hearing aids all the time. FM use is really interesting because it's probably situationally dependent. And we have families that we're aware of that get an FM system for home use, for example, and they use it all the time. And the problem with the FM signal in that context is that you're only having access to that one talker. So in a classroom, when a teacher is teaching, that's exactly what we want. If you're in a social situation with multiple talkers who you want to be able to hear, that's not ideal because there's typically just that one microphone in most systems that we use presently. So we can't make the same generalization that all FM use is good FM use because we see some situations where children might have reduced access to things like overhearing, but we're trying to characterize those situations not only so that we can better instruct families about how to use FM, but so that we can look at how FM use might affect performance on some of these tasks. Because I think eventually with the speech recognition and noise and reverberation stuff, even if children do really well, we're still going to need to give them FM systems. I mean, I don't think their outcomes are ever going to be so good that that's going to happen. But I think we can have more data to support the situations where FM would be more useful. So we are looking at that. And it's interesting, the kids at North Carolina all got FM systems as part of their early intervention process. So we have this group of kids at North Carolina who've had FM since they were babies, and the really interesting thing is very few families are using it. So they have it, but I don't know if they don't know. So this is something we're going to try to dig into, because originally we thought it'll be really cool. These kids at North Carolina are going to be doing so well because they have FM. And we went and looked at it, and most of them are like, yeah, we don't use that. So we're following him to school and see if that continues.
Anything else? All right. Oh, yeah,
Yeah,
Stephen.
one quick one. What do you think's the explanatory mechanism for the degradation, the companion slide
The next one.
in noise?
So you could argue in the variability, we're only in the group of children with hearing loss, that there might be some process that's related to hearing loss that's creating that problem, like spectral resolution or temporal resolution or something like that. But the fact that we're seeing it's not as much variability, but quite a bit of variability in our group of kids with normal hearing makes me wonder if it's not cognitive or linguistic or some top-down processing thing, because these kids all have the same fidelity of the signal, and these are an age, because we're only looking at first and third graders in this study, is not a strong predictor because we really only have two different groups of children, and there's a lot of overlap between the first and third graders, believe it or not. So we think that some of this individual variability is related to working memory and language ability, individual differences. But if that's the case, then that argues that we should work on those things for children who are hard of hearing, because that could be something that they could use even if we can improve the audibility of the signal beyond a certain point.
So what accounts for that slope, though, the declination as a function of hearing loss?
Yeah, so there is, what you do see an audibility effect in these data for sure, and And that is just our ability to sort of fit the hearing aid gets poorer as your degree of hearing loss increases. So another way to look at that is this slide with audibility as a function of degree of hearing loss. The hearing aid can only do so much at these higher levels, and that's why even if you're matching your prescription, the amount of audibility that you provide goes down as a function of the degree of hearing loss. So there's certainly some of that, but there's also, I think, other things that are contributing to it, and that's what we're trying to tease apart.
Like, what's the general assumption about outer hair cell function?
So the general assumption about outer hair cell function is that the amount of...
Especially as loss increases.
Yeah. So the assumption here is that up to about 70, there's an increasing amount of outer hair cell damage as you increase from mild hearing loss to 70 dB, and then at 70 dB and greater, because that's where the cochlear amplifier sort of, the limits of the cochlear amplifier, that above that level, that's where we're starting to see inner hair cell loss as well. But that's the assumption of sort of Brian Moore's model of loudness, for example. But the etiologies of these hearing losses are going to play a role in that too. So we know that there are some of these kids might have connexin 26, for example, which we know might be isolated to a very specific part of the cochlea or specifically to the outer hair cells. And so I think etiology plays into that as well. And unfortunately, one of the things we discovered in this process is that we need to do a lot better job offering genetic testing to these families of children with hearing loss, because we knew about the etiologies in very few cases of these, and I think that would help us, because there are things like otofurlinopathy that we know are isolated to the inner hair cells that could influence your approach with those kids, for example. So, thank you.